presentation, I would like to invite Professor Dr. Rajesh Balakrishnan, Professor and Head Unit 3 Radiation Oncology, CMC Vellore. He will be discussing on current management guidelines based on WHO CNS5 classification. Sir, we welcome you to deliver your speech.
Yeah, good afternoon. Can you hear?
Yes, sir, we can hear you.
Yeah. I would like to thank Shajal, Arnakshuda, Dr. Kafijaman sir, Dr. Salim Raja sir for inviting me for this talk. What today I will do is, just now we heard from the pathologist and the neuro-oncologist about the management, about the classification and pathological processes. I will just dive into other parts. So what I would like to start is we need to have an integrated approach for having a better patient outcome. So for having an integrated approach, I mean like you need to have a neuropathologist, a neuroradiologist, a neurosurgeon, radiation oncologist. Not only that, you might also need to have occupational therapy and physiotherapy also to have a better patient outcome. So you need to have a comprehensive setup whenever you try to manage a patient with brain tumor. Along with this, I said like neuropathologists, they should have advanced diagnostic molecules and molecular profiling whenever it is possible to get. And the treatment is now basically targeted based on the targeted tumor molecule, whatever you get it as a. So basically, if you see the neuroepithelial cell, it has two progenitor cells. That is the neuronal progenitor and the glial progenitor. And neuronal progenitor, they develop neurons. And the glioneuronal tumors are apart from this. So the glial progenitor cells, they have differentiate into astrocytomas and oligodendrogliomas. So these tumors, they develop into gliomas and oligodendrogliomas. So basically, we had a in 2016, we had a classification of tumors which was a bit confused. So in the 2021 update, they made it a bit simpler and they classified them into three groups: astrocytomas, oligodendrogliomas, and glioblastomas. So I think we have heard about this. I just continue with this. So there's one question like what molecular testing is necessary? These are the 7 molecular testing which is very essential for diagnosis. One is the IDH mutation. It can be done with the IHCs. ATRX gene expression, that is also can be done with IHCs. And if ATRX gene is retained, so then you have a possibility that this could be a oligodendroglioma, and you can try to do a 1p19q2 correlation to check whether it is positive. Then it might imply it is a oligodendroglioma. The other tests which are necessary is the CDKN2A homozygous deletion, third mutation, EGFR amplification, histone H3 K27 mutations, and histone H3 G34 mutations. So there are 4 tests out of which can be done with IHC and 3 are done with FISH. So why it is important to know about this mutation test? All mutations are exclusive in specific areas. If we see IDH mutations, they are most commonly restricted to frontal and temporal lobes. ATR mutation, they are restricted to brainstem and cerebral hemispheres. H3K27, it's mostly in the midline. It's seen in the children. It's in the pons or the brainstem region. And most of the time, when we have H3K27 mutation, they have very poor prognosis as well. H3G34 mutations. So H3G34 mutation, they are seen in the cerebral hemisphere. H3G34 mutations also have a poor prognosis, but when compared to H3K27, it is slightly better. So coming to molecular based class management based on molecular classification. So these are the different sort of molecules which can be seen like MGMT, IDH, ATRX, 1p19q, co-deletion, and other things. One thing I think Tarun didn't mention is it is not age group, it is the type of tumors. It's not adult versus pediatric. It is a pediatric type versus an adult type. If you see this graph, here you can see like this is given into 25-year blocks. The pediatric type diffuse gliomas, they will be even seen in a patient who's 25 to 50 years as well, but the incidence is less. So you have pediatric type gliomas, the adult type gliomas. Pediatric type gliomas, as the age increases of the patient, the incidence comes down. And for the adult type diffuse gliomas, as the child grows into an adult, the chances of becoming an adult type glioma is very high. How these two are differentiated is pediatric type gliomas, they have histone H3 and RAS pathway. They progress to the histone and the RAS MAP kinase pathway. But that adult type diffuse gliomas, they progress to the IDH mutation and the 1p19 co-deletion pathway. So this is how both this adult type tumors and pediatric type tumors they differ. So broadly to divide, gliomas divided into adult type diffuse gliomas, pediatric type diffuse gliomas, where you have a high grade and a low grade as well, circumscribed astrocytic gliomas and ependymal tumors. So what I'll do is I'll just try to skip the slides because these are all almost repetitions. To just to give you a good idea, like adult diffuse gliomas, you can differentiate them into mutation IDH mutant and IDH wild type. So IDH mutant type tumors, they do very well. Their prognosis is good. So if you have an IDH mutant plus an 1p19q co-deletion, that is called as a oligodendroglioma, and this tumor has the best prognosis. If you have a patient who's having IDH mutant and 1p19q is not co-deleted, or you see like the patient has an ATRX which is lost. So 1p19q and ATRX, they are mutually, that is like if a patient is having ATRX loss, the chances for them to have 1p19q co-deletion is almost 99% not there. So we can say like it could be a surrogate marker for 1p19q co-deletion. If you have ATRX lost, it is 1p19q non-co-deleted. If you have ATRX which is retained, then there is a very high chance that the patient could be having 1p19q co-deletion. So for a patient who's having IDH mutant astrocytoma, there are three grades, grade 2, 3, and 4. They have slightly better prognosis than the glioblastoma, but slightly inferior prognosis to the oligodendrogliomas. So glioblastomas, they are IDH wild type, grade 4 tumors, and they are classified based on the absence of the IDH mutation. So they have the very poor prognosis when compared to all the other types of tumors. Okay. So how the molecular marker is very important, because even for a patient who's having an astrocytoma IDH mutation, if you have a molecule CDKN2A which is positive, so then even a grade 2, grade 3 tumor can become grade 4. Similarly, for a patient with an IDH wild type tumor, grade 2, grade 3 also, irrespective of the thing, they become glioblastoma. If they have a third mutation, EGFR mutation, 7 plus chromosome and 10 minus chromosome. So this is the classification of an adult type gliomas, which is divided into different types, basically given the essential diagnostic which is put as a red, and the optional ones is the one which is present in the blue. I'll just skip this slide because this slide doctor has already, the pathology doctor has covered it. So coming to the management part of IDH mutant gliomas. So IDH mutant gliomas, as I said earlier, it could be oligodendroglioma grade 2, oligodendroglioma grade 3, diffuse astrocytoma grade 2, 3, and 4. So the factors which is to be discussed before we do is, there are some favorable factors. That is the age less than 40, patient doesn't have neurological deficit, the tumor burden is less, or a grade 2 histology. These are all favorable factors. Less favorable factors are a patient is a slightly older patient, age is more than 40, there is some neurological deficit, the surgeon has not done a cross-scrotal resection, he has left behind tumor, or the grade of the tumor is grade 3. So if it is a favorable tumor with a grade 2, then there is an option of wait and watch, or you give radiotherapy followed by PCV. Temozolomide chemotherapy is also being considered in places of PCV, basically because of toxicity of PCV and the difficulty in following the schedule for the PCV. Even in the published trials, whichever have shown benefit, only around 40 to 45% of the people have completed the full course of PCV regimen, rather than fully completing all the courses. It's only like the complaints is only around 50% of them. Coming to the less favorable group, where the age is more than 40, neurological deficit, or there is a residual tumor present, the treatment is going to be radiotherapy followed by PCV or a temozolomide with chemo. This PCV is basically restricting only to oligodendroglioma, and whenever the histology is astrocytoma, we can definitely go ahead and give temozolomide rather than PCV. For a patient with a grade 4 tumor, the prognostic factors or still the same, but you might need to also see whether there is homozygous CDKN2A deletion present or not. If it is present, the prognosis is going to be bad than one who don't have it. So the treatment of choice is going to be temozolomide with concurrent chemo-RT. And for a poor prognostic factor patient who is having a poor KPS, we can give with or without concomitant temozolomide also could be tried. So coming to wild type, that is a glioblastoma. Here the management is like immediately after the surgery. It could be either a resection or a biopsy. You definitely need to have a post-operative CT scan or an MRI to look at baseline how much is the residual tumor. And then you look at the age of the patient and the performance status of the patient and the MGMT status. Three important things to check. If the patient age is less than 70 years and KPS is more than 70, it is a very favorable prognostic group. And this patient can go for temozolomide chemo-RT with or without chemotreating field. Chemotreating field technique is not available anywhere in Asia. And in case you want to refer a patient for this, patient has to go either to Europe or to the North American countries. The less favorable prognostic factors are KPS more than 70. If the patient's KPS is poor, then you can consider for a hypofractionated RT where you can give a dose of 40 grain 15 fractions or 50 grain 20 fractions with or without concurrent temozolomide. If the patient is having unfavorable prognostic factors, that is the age is more than 70 and the MGMT methylated is unmethylated. So here also you can just consider radiotherapy hypofractionated, or you can also if the patient is MGMT is methylated, then you can go for temozolomide as a monotherapy as well. So if it's a very unfavorable, poor prognostic factor such as poor KPS is less than 50, inability to consent for treatment, best supportive care is the way to go, or enroll them in any clinical trial. So coming to the next part about the management of diffuse type, pediatric type diffuse low-grade gliomas. As said earlier, it has 4 types. One is through the MIP pathway, other one is the angiocentric glioma, the other one is the plenty and the MAP kinase pathway groups. So here, basically you can divide all these pediatric diffuse low-grade gliomas, they're all wild type, IDH wild type, they don't have the IDH mutation. So here the pathway is either through RAS MAP kinase pathway or a non-RAS MAP kinase pathway. If it is through the RAS MAP kinase pathway, it is basically you have 2 genes, which is the BRAF and the FGFR gene. And through the non-RAS MAP kinase pathway, you have the PIRCA and the MIP type. So there are, you can classify them into low-grade and circumscribed astrocytomas. So if you see, most of the time, the choroid glioma and the SEGA, they will present along the lateral ventricles and in the midline. Plenty and PXA will be seen in the peripheries. And the pilocytic astrocytomas and the high-grade glioma, high-grade glioma with astrocytic features, that is with the piloid-like features, H-gap, they will be seen in the posterior fossa, that is in the midline and the cerebellar part. So how do you manage this low-grade gliomas? Basically, you need to assess whether the patient is having a low risk for progression or a high risk for progression. If the patient is having a low risk for progression, monitoring is a good option. Monitoring is suitable for low-grade traditional management. It is one. If the other option is to put them on carboplatin and vincristine, when you feel that the patient is slightly at a higher risk for recurrence, then you can start them with carboplatin and vincristine. If the patient is having a high risk for progression and you see that there is some molecular agent which is molecular pathway is targeted, then we can definitely use them. So MAP kinase pathway inhibitors, they are effective for high risk targeted therapy. So this is a broad outline. Coming to the next part, that is the high grade gliomas. In pediatric type diffuse high grade gliomas, all these pediatric type tumors will be IDH wild type. So here the mutations are 3. One is the H3, could be H3K27, H3G34, and the NTRK pathways. So NTRK, ROS, ALK, and MET alteration pathway, they are most commonly seen in the infant or the hemispheric infant with the lesion in the hemispheric location, and this is called as infantile type hemispheric gliomas. If the patient is in the lesion is in the midline and it is H3K mutant, it is a diffuse midline altered midline glioma with H3K27 altered. There is in a younger age group, there is a pediatric age group or an younger adult. If the lesion is hemispheric and has a H3G34, it becomes a diffuse hemispheric H3G34 mutant tumor. and the other ones becomes like H3 wild type and IDH wild type grade 4 tumors. So this is the broad classification how you divide based on the markers. So out of this, if you see the diffuse midline gliomas, that is the H3K27 altered, they have the very poor prognosis when compared to all the other type tumors. So how do you manage this H3K27 altered or diffuse midline gliomas? One thing we need to check is whether the patient is fit for a biopsy. If possible, always try to get a stereotactic biopsy because it's essential for having for molecular diagnosis, and in future we can enroll them for any clinical trials also. Once the patient is not fit for a biopsy, there are some places where you can directly consider for RT on clinical radiological diagnosis. Diffuse midline glioma is one place where even if you're not able to do a biopsy, but the radiological features are suggestive of a diffuse midline glioma or a diffuse pontine glioma, then you can go ahead with focal radiotherapy for this patient. This will be the standard of care. For these tumors, temozolomide is ineffective because they don't lack the MGM, they lack the MGMT promoter methylation. So most of the time, these patients will progress within 7 to 8 months. When they progress, re-irradiation still we can consider if the progression is more than 6 months, 6 to 12 months. More than 12 months is very safe. 6 to 12 months is bit difficult, but there is no other options available. Sometimes if you have a ability to use the molecular markers such as ONC1, which could be also tried. ONC1 is not available in Southeast Asia. We might need to import it from the European places. There are some other management also which is possible for diffuse high-grade gliomas. You can have this epigenetic therapy where you try to modify based on the molecular things available. You can have histone inhibitors, transcriptional modifiers, proteasome inhibitors, dopamine inhibitors, mitochondrial CLPP target inhibitors, or a CAR T cell therapy or a vaccine. So all these things could be tried, but everything doesn't have a survival advantage when compared to not using them. Coming to the next topic, that is the H3G34 mutant diffuse hemispheric gliomas. Here, one molecule which helps us to target our treatment is the MGMT. If MGMT is methylated or an MGMT is unmethylated. For a patient who has an MGMT unmethylated disease, unmethylated tumor, but the tumor is limited. So these patients we can consider for local field radiotherapy or a focal RT. And if the lesion is disseminated, it's a large lesion, then we get to go for whole brain RT. There are only very few conditions where we give whole brain RT currently for gliomas as such. So if a patient is having MGMT methylated, surgical resection is the first choice for both the tumors. If it's an MGMT methylated or unmethylated, surgery is the treatment of choice. But surgical resection, we try to get for a what you call like a gross total resection whenever possible if it is a methylated one, because the benefit is going to be high. And if the tumor is methylated, then definitely temozolomide along with the RT is definitely going to help for this group of patients. So coming to the next one, the next step, that is which is both H3 wild type and IDH wild type. In this tumor, the standard of care is maximum surgical resection followed by focal radiotherapy. And temozolomide and lomustine can also be combined, and we can have some survival advantage when compared to the others. Checkpoint inhibitors is the one which is coming up for this group of patients because these patients have a very high mutational tumor burden, and there is DNA mismatch repair also happening. So nivolumab has been found to be useful in this particular group of patients. So coming to the next one, that is the infantile hemispheric gliomas. Infantile hemispheric gliomas, surgery is the treatment of choice. Complete removal of the tumor because gross total resection has improved the outcomes. After the surgery is over, you go for radiation. Whenever you plan for radiation, you have to go for a conformal technique or a proton beam therapy. Basically, because this usually happens in young children, so radiation will be having a lot of side effects, and better to reduce the side effects with the specialized technique of RT or with particle beam therapy. So chemotherapy is the one which you try to give after surgery. After surgery, go for chemotherapy, and if the chemotherapy fails, then you can go for radiation. This regimen of surgery followed by chemo by radiation, it helps us to prolong the time gap between the irradiation and the child growth of the brain growth of the child. So chemotherapy, the indications are basically incomplete resection or for recurrence. The chemotherapy most commonly used is the vincristine carboplatin group or the temozolomide thiotepa. You tailor the chemotherapy according to the age. When the child is less than 3 years, you basically start with vincristine and carboplatin. It is much safer than the other group, thiotepa and the temozolomide. Targeted therapy which is available for this is basically, if you remember, this infantile hemispheric gliomas, they will have ALK mutations, NTRK mutations, and MET fusion mutations. So tyrosine kinase inhibitors will also play a role here. So coming to the next part, that is the circumscribed astrocytic gliomas. There are 4 types basically. Circumscribed astrocytomas. This is the primary treatment is always surgery for any sort of astrocytoma. For circumscribed, you try to aim for a gross total resection and keep the patient on follow-up. When the patient recurs, you again go for a repeat surgery, and then if there is a incomplete resection, you go for radiation. For pilocytic astrocytomas, first is surgery. Sometimes you can also have an observation for this group of patients. If the lesion starts to increase in size, then you can go for surgery. MAP kinase pathway inhibitors are also can be tried to prolong the duration for the next one. And if the the lesion is not fully resected and the patient's age is in the more than 10 years or something, then definitely you can consider for radiation. For pleomorphic xanthoastrocytomas, surgery followed by radiation is the treatment of choice. Plus minus concurrent temozolomide for grade 3. We at CMC, we try to give for pleomorphic xanthoastrocytomas concurrent chemotherapy as you do for a glioma, like a concurrent temozolomide followed by adjuvant temozolomide. If the patient is having a recurrence, and most of these tumors, PXs, they have a BRAF mutation, so we can give BRAF inhibitors as well. So there's one more circumscribed astrocytoma that is called SIGA. SIGA is subependymal astrocytoma. So for this, observation is the treatment of choice. You monitor SIGAs without any immediate intervention. When the lesion starts to grow and it causes symptoms, then you try to resect them. And everolimus is a mTOR inhibitor which can be given as a supplement along with radiation, along with surgery. And if the patient is not able to afford for everolimus or the lesion is growing fast, then you can consider radiation as a treatment of choice. So just to bring through all the targeted therapies which are available, for a glioma with the pilocytic astrocytoma, you can give MEK inhibitors. For infantile type hemispheric gliomas, because they have ALK, ROS, and NTRK MET fusion, we have specific targeted tyrosine kinase inhibitors for this. For FGFR mutations, we have FGFR inhibitors. For IDH mutant gliomas, specifically, there is some molecules such as vorasidenib and ivosidenib. I don't have any experience in using these molecules. For pleomorphic xanthoastrocytoma, BRAF inhibitors can be used. Similar thing for SIGA, you can use the mTOR inhibitors, that is the everolimus. And GD2 inhibitors and the CAR T cell therapy is basically reserved for H3K27 altered diffuse midline gliomas. The other group of gliomas, they don't show any benefit with the CAR T cell therapy. So we have just completed the section on gliomas, and I'll just move fastly through ependymomas. So when you have a patient with ependymoma, you need to evaluate for history, physical examination, and look for signs and symptoms of raised ICT, because the ependymoma most common location is the posterior fossa. So when you do an imaging, when you suspect ependymoma, always you try to do a brain imaging along with spine. With and without contrast, and we need to also do a lumbar puncture to see whether there's any CSF dissemination. There is a raised ICT, you consider for a VP shunt or a ventriculostomy prior to doing the main surgery to the tumor. Maximum safe resection is the treatment which is definitely required, and CSF cytology, if not done preoperatively, you do it after 2 weeks. So there is a separate staging for residual disease for ependymomas. If it's a R0 resection status, whether it's a residual disease is R0, if there is no tumor seen. R1, if the residual tumor is not seen on imaging, but the neurosurgeon says he has left behind some tumor. R2 is the tumor is less than 5 millimeters, but you cannot measure in all 3 planes, that's the axial, coronal, and sagittal. R3 is it's more than 5 millimeters, and you can measure in 3 planes. So the management, the principles is like surgery, always you aim for a gross total resection. because subtotal resection has a worse prognosis. If we have 5-year overall survival for a gross total resection is 80% when compared to subtotal resection, which is around 47%. So if you have a patient who has an ependymoma come to you after surgery, there is a residual tumor, please send them back for the neurosurgeon to ask whether whether a resection can be thought of. So subtotal resection is worse, always think of resurgery. So workup is like as I said earlier, MRI brain and an MRI spine and a CSF cytology is necessary. Radiation, very few places where we can give radiation for a small child. Here in ependymoma, the current guidelines say you can treat the child with radiation if the age is more than 12 months. If the age is more than 12 to 18 months, their dose of 54 grays given to the residual tumor or the tumor bed. If the age is more than 18 months, you give a dose of 59.4 gray in 33 fractions. If you find that the CSF is involved or there is a drop meds, then you give a CSA dose to 36 gray and the tumor bed usually should boost up to 54 to 59.4 gray. Always have a time gap of at least 4 weeks after the surgery prior to you start the radiation. So chemotherapy role is very limited. There are a lot of trials currently which is ongoing to see whether you can convert the subtotal resections into resectable disease on clinical trials. So chemotherapy can play a role there. And if the age of the child is less than 12 months, you can do some bridging chemotherapy to bring the age up to 12 months and after that go for radiation. So here the chemotherapy is always either an adjuvant or a neoadjuvant. It is not concurrent. So this is the guideline for management of intracranial less than 12 months, which is in the third page. Surgery, consider for resurgery in case there is a big residual tumor. If the age is less than 12, you consider bridging chemotherapy and then take for radiotherapy. If the child is having the age of the child is more than 12 and the residual is not there, surgery followed by radiation directly. If there is a residual, you consider whether you can have a resurgery or you can consider chemotherapy to have on a clinical trial basis, and then you go for radiation. So this is the one for intracranial ependymomas. The spinal ependymomas, they are slightly managed in a different way. Here, for each location, the treatment plan is different. For a patient who's having MIC amplification, there is no role for observation. Surgery, if there is a residual tumor, large residual tumor, consider for what you call resurgery and then put for RT. If the patient is having lesion in the myxopapillary ependymoma, waitful watching can be done if the residual is not there. If there is a residual, always consider for RT. So how do you treat ependymomas? Initially, we had been using preoperative CT scans to contour the volume. Currently, we have moved from there to postoperative imaging for the volume. Earlier, we have been restricted the range of radiation to 36 months in the old studies, and the current studies, that's the ACNS 0121 and the 0831, has said that any patient who is having more than age of 12 months can be considered for RT. And the margins which we were giving earlier 2 centimeters is now reduced to 0.5 centimeters. So the volume of treatment is going to be very less. So you can definitely go ahead and give radiation even for a small child. So the dose is equivalent of 59.4 gray in 1.8 gray per fraction for a child who is more than 18 months. And for a child who is 12 to 18 months, you can give a dose of 54 gray. So when do you consider focal RT and CSI for ependymomas? Less than age 3, generally avoid CSI. For any patient who's having MIC amplified spinal ependymomas or a disseminated disease in the spine or the other places, then you consider CSI. All other patients, you have only focal RT as the treatment of choice. Coming to the next part, the medulloblastomas. As said, there are 4 types. Wind activated and the SSH activated and the non-wind and the non-SSH type. So each one has their own prognosis. So for treating medulloblastomas, you classify the patient into having what risk, whether it's a standard risk or a high risk. Standard risk meaning you should have all these features. There is the age more than 3 years. Residual tumor after the surgery is less than 1.5. CSF is negative, MRA is negative, and it's a classic or a desmoplastic pathology. But if the patient is less than 3 years or 1.5 centimeter residual or a CSF positive or MRI spine shows leptomeningeal disease or it's a large cell or anaplastic subtype, it's a high risk. So this is the CEOP classification for developing countries. It's not for other places because there, once you have a molecular risk categorization, it's slightly different for this. There, the residual tumor doesn't come. So, based on the molecular classification, you can classify them into Wnt pathway, SSH pathway, group 3 and group 4, where the risk categorization can be done into low risk, standard risk, high risk, and very high risk. So, some chromosomes which we need to check is the chromosome 11. For group 4, the loss is good, and for group SSH pathway, chromosome 14 is there where the loss is bad. And the Wnt pathway is the one where we can try de-escalation of treatment. For all others, there is no point to de-escalation. So de-escalation in the sense, for a patient with average risk, you give a dose of 23.4 gray and boost it up to 55 to 58 gray. For a patient with high risk, you give a dose of 36, 39 gray and boost up to 55 to 58 gray to the tumor bed. And if there is a drop meds, you need to boost the drop meds also up to 45 gray. De-escalation in Wnt therapy is possible from 23.4 CSI, you can reduce it to 18 gray. So there is the role of concurrent chemotherapy is almost disappearing in medulloblastomas, and only for grade 3 medulloblastoma, there is some role of adding concurrent carboplatin with RT, but that schedule is bit tedious and a lot of complications are present with with a slight advantage in the overall survival. So after chemotherapy, after the concurrent chemotherapy that can what we call the CSA is over, you give a gap of 4 to 6 weeks and then start them on adjuvant chemotherapy with a combination of Packer's regimen. There is a vincristine, cisplatin, cyclophosphamide, CCMU, which can be given for 6 to 8 cycles. So medulloblastoma is one of success stories because the 10-year survival will be in the range of 80 to 90%. So you should clearly know like when to give CSA, how much dose to give, because if you miss that the first time, the chances of cure for the patient is lost. Coming to the last part about the meningiomas, I think we had already covered like what is grade 1, grade 2 and grade 3. We can classify the risk group here also. For a patient who's having a grade 1 meningioma, if there is a gross total resection or a subtotal, whatever it is, it's a low risk category. For a group 2, it will be like a grade 2 patient with a gross total resection or a grade 1 patient which is a recurrent tumor. Grade 1, when it recurs, it becomes into intermediate risk. Grade 3 would be any grade, group 3 will be high risk group. There is any grade 3 tumors or any grade 2 or grade 3 which is recurrent. So why it is important is for a low risk category, you can just observe and no need for any radiation. For a group 2 or an intermediate risk, you have to consider them for radiation for a dose of 54 gray in 30 fractions. And for a group 3, which is high risk, you have to give a higher dose of 60 gray in 30 fractions to the tumor bed, and to the margins, you have to give a dose of 54 gray in 30 fractions. So whenever possible, you can use IMRT. If IMRT is not there, definitely you can consider 3D CRT for 54 gray in 30 fractions, followed by a sequential boost to the tumor bed to 60 gray in 30 fractions. In 2 phases, you can consider. So this is our neuro-oncology team. I would like to thank the organizers for giving me an option here to talk and take up questions.
Thank you, sir, for providing a concise yet comprehensive overview of the current management protocols based on the latest classification. It was immensely valuable.